Hi everyone, Professor Babe here. This lecture is on urinary system disorders. The previous one, if you haven't watched it yet, watch that first. That is the one on the urinary system overview. In this lesson, we're going to cover the different types of urinary disorders. We're going to build on the understanding of the normal urinary anatomy and physiology, examine what happens when the kidneys and the urinary tract become diseased. As we progress through the lesson, please focus on how each disorder affects normal filtration, fluid balance, electrolyte regulation, and waste removal. Many of the urinary system disorders begin with localized damage, but eventually affect multiple body systems. And the kidneys play such a vital role in maintaining this homeostasis. Here are the lesson objectives. So we're going to begin with, the different urinary tract infections, follow the progression of the disease from the lower urinary tract to the kidneys. Next, we'll discuss inflammatory disorders involving the glomeruli, followed by obstructive disorders, vascular disorders, congenital disorders, acute kidney injury, chronic kidney disease, and finally, end-stage renal disease. Now, urinary tract infections, UTIs, are among the most common bacterial infections encountered in healthcare. Most UTIs occur through an ascending route. Bacteria enter through the urethra, colonize the bladder, and may continue upward through the ureters into the kidneys. So they tend to be ascending. They start in the bottom, go all the way up to the kidneys, causing kidney infection. The body's normal defenses include continuous urine flow, acidic urine, because remember we talked about the normal pH of the urine. It has to have certain amount of acidity to kill bacteria. That's your defense mechanism. Intact mucosal barriers and complete bladder emptying. You don't want to, we don't want urine retention, right? We don't want the bladder to empty completely. So now when these defenses are compromised, infection can develop. E. coli is responsible for approximately 80 to 85% of UTIs. It normally resides in the GI tract and can easily migrate into the urinary system. As bacteria multiply, inflammation develops, producing redness, swelling, pain, and irritation of the urinary tract. Now, a urine analysis is the primary diagnostic test used to evaluate UTIs. Common findings will include pyuria, bacteriuria, microscopic hematuria, positive leukocyte esterase, and positive nitrates. In pyelonephritis, urinary casts may be present, indicating renal involvement. Treatment typically includes antibiotics such as nitrofurantoin or Bactrim, amoxicillin, depending on the culture results. Because remember, the standard is to do a culture insensitivity to figure out which antibiotic would work. Adequate hydration is important because increased urine flow helps flush bacteria from the urinary tract. Here is a cheat sheet on UTIs. It goes over the the risk factors, diagnostics, treatments, and different types of, UTIs and their manifestations. Now, lower UTI tract infections include cystitis and urethritis. Let's begin with these. Cystitis refers to the inflammation of the bladder, while urethritis refers to the inflammation of the urethra. Urethritis, itis meaning inflammation. When bacteria attach to the mucosal lining, the tissue becomes inflamed and edematous. The irritation stimulates sensory nerves, and this produces dysuria, urgency, frequency. With the urine. Patients often report burning during the urination and suprapubic discomfort, cloudy urine and they might end up with cloudy and foul-smelling urine. Unlike upper UTIs, systemic symptoms are usually mild or absent. Diagnosis is primarily made through a urine analysis, which reveals bacteriuria, pyuria, positive leukocytes, and nitrates. Now, upper UTI, UTI infection is pyelonephritis, right? So this involves the renal pelvis and the kidney tissue. The disorder develops when bacteria, remember we said UTIs tend to be ascending. So when bacteria ascends from the bladder into the kidneys, the infection causes inflammation, edema, and infiltration of the white blood cells into the renal tissue. Severe infections could produce abscesses in the kidneys, scarring, or permanent nephron damage, right? And because the kidneys are involved, symptoms are much more severe than those seen with just the bladder infection, the cystitis. So, because remember, we said the kidney has a lot of functions, right? We discussed this in our overview lecture. The kidney has a lot of functions. So if the kidney is infected and can't perform those functions, it can cause the spiral of events. So patients often present with high fever, chills, flank pain is a standard sign of it. It's like hallmark sign of kidney infection, nausea, vomiting, malaise, costovertebral angle tenderness. Basically, that's around your flank pain. If untreated, pyelonephritis can progress to sepsis, acute kidney injury, and permanent renal scarring. Now, moving on to inflammatory disorders. While infections affect the UTI, urinary tract lining, inflammatory disorders often affect the glomeruli themselves, right? Because the glomerulus is responsible for filtration, damage at this level can significantly impair kidney function and alter fluid balance. So inflammatory disorders primarily affect the glomerular GFR, glomerular filtration membrane, in acute post-streptococcal glomerulonephritis, antigen body complexes become trapped within the glomerular capillaries. This triggers type 3 hypersensitivity reaction that causes inflammation and cellular proliferation. So now the inflamed glomerulus becomes more permeable. So now when it becomes permeable, it allows proteins and red blood cells to leak into the urine because now the lining is permeable. It's allowing the big particles to leak through. So at the same time, the swelling and the congestion, they reduce the filtration rate, lead to fluid retention, edema, hypertension, and accumulated waste products. Nephrotic syndrome and nephritic syndrome both involve glomerular injury, but differ significantly in their clinical presentation. Here is a cheat sheet on glomerulonephritis. Please review it. It covers the patho of it, diagnostics, treatment, all the good stuff. So it's basically characterized by inflammation of the glomeruli, and this leads to impaired filtration because now the glomeruli are inflamed and they can't do their job, which is to filter. Now, patients often develop hematuria, producing classic tea-colored smoky urine appearance. That's what you'll normally see when when the kidney is involved, right? Because the filtration is decreased, sodium and water are retained. So now they're not excreting the sodium in the water, and they're not filtering those particles. This leads to hypertension, and edema, particularly around the eyes. So you're going to see the dark urine, the smoky tea-colored urine. You're going to see the swelling around the eyes, the edema. Lab findings will often show proteinuria, protein in the urine, hematuria, blood in the urine, elevated BUN, right? Elevated creatinine and decreased GFR. Because remember, the filtration rate is going to be decreased because the glomeruli are inflamed. Treatment focuses on controlling the inflammation, managing blood pressure, and restricting sodium and fluid intake because now they're edematous, so you want to restrict sodium, and the patient will always be on fluid restrictions in this case. Nephrotic syndrome and nephritic syndrome. It's really important to distinguish between nephrotic syndrome from nephritic syndrome. Nephrotic system is characterized by massive protein loss through the glomerulus because remember they become permeable, right? And so it's losing protein out of the glomeruli into the blood. The resulting hypoalbuminemia decreases plasma oncotic pressure. So now if you have low protein, there's going to be low oncotic pressure because remember we talked about this in our fluid and electrolyte lecture. that proteins tend to cause oncotic pressure, where basically it pulls fluid towards it, right? So now when you don't have enough protein, then it decreases the plasma oncotic pressure. This allows fluid to shift into tissues and causing generalized edema or anasarca, right? So basically the fluid it can't get pulled into the vascular system, and so it's in the tissues causing edema. So patients commonly develop hyperlipidemia and lipiduria, lipids in the urine. And nephritic syndrome, on the other hand, is characterized by inflammation, hematuria, oliguria, hypertension, and mild to moderate proteinuria. So one helpful way to remember the difference is that nephrotic syndrome primarily involves protein loss, huge, massive protein loss, while nephritic syndrome primarily involves inflammation and bleeding, right? There is some protein loss, but not in the same amounts as nephrotic syndrome. Now let's talk about obstructive disorders. These basically interfere with normal urine flow. If it's obstructed, it's not going to flow, right? So when urine flow is backed, pressure builds up within the urinary tract. This pressure damages renal tissue, reduces filtration. Persistent obstruction, if the obstruction is not removed, can eventually lead to hydronephrosis, infection, ischemia, and chronic kidney failure. So urinary tract obstructions include urolithiasis, refers to the formation of kidney stones. That's what we call kidney stones. Stones develop when urine becomes supersaturated with minerals such as calcium, uric acid, cysteine, or struvite. As the stones move through the urinary tract, they produce severe flank pain known as renal colic, hematuria. They cause nausea and vomiting. Hydronephrosis occurs when the obstruction causes the urine to back up into the renal pelvis, like it's going further back up, further up. The increased pressure compresses the renal tissue and reduces blood flow. So now the blood can't flow through the renal nephrons and stuff because it's blocked, right? So the urinary tract tumors also can cause obstructions in the urine flow. Bladder cancer commonly presents with painless hematuria, while renal cell carcinoma often presents with hematuria, flank pain, and palpable masses. This cheat sheet here has a lot of the information. Please review this. You can print it out and use it to, as a reference to study about nephrolithiasis, kidney stones, and vascular disorders. They basically impair blood flow to the kidneys because now the problem is the vascular system, which is transporting the blood through the kidneys. Now, because kidneys receive, like we mentioned, about 1/4, 20 to 25% of the cardiac output, adequate blood flow is essential, really important for filtration. Now, when blood vessels become narrowed or damaged, or chronic ischemia develops, and nephron loss can occur. So if there's no blood flow, then you're going to have ischemia in the nephrons. So vascular urinary disorders include nephrosclerosis, right? As you can see here, this is an ischemic where the nephrons are not getting enough blood flow. So the nephrosclerosis refers to the thickening and hardening of renal blood vessels. The two most common causes are chronic hypertension and, let's guess, diabetes mellitus. The two big culprits, which influence almost every part of your body. Now, over time, these narrowing vessels reduce blood flow. They cause ischemia, glomerular destruction, nephron loss. The kidneys respond by activating the renin-angiotensin-aldosterone system because remember, now you're not having enough flow. This increases the blood pressure and further worsens vascular damage because the blood flow is increasing because remember, if the blood vessels are hardened or narrowed, they're not getting enough blood to the kidneys. So the kidneys think, oh, we're not getting enough flow. Let's release renin and let's get the RAS system initiated. But now when more blood starts coming through those vessels that are already narrowed, that's going to cause even more damage. Now, so patients typically develop hypertension, proteinuria, because now proteins are being excreted, elevated creatinine, and progressive renal insufficiency. So that's further damage to the kidney, right? I mean, it's going to end up with kidney injury or, end-stage renal disease, things like that. We don't want to damage the kidney. We want to prevent it from reaching that point. Congenital disorders, these are some urinary disorders that are inherited or occur during development. So these often lead to progressive kidney dysfunction over time and may require lifelong monitoring. And in adults, it's the polycystic kidney disease, PKD we call it. And in children, developmental one is Wilms tumor. Here's a cheat sheet for both of those. Please print it out and use it to review these diseases. Now, adult PKD, right, disease is an inherited disorder characterized by multiple fluid-filled cysts throughout the kidneys. So you just have these bunch of cysts all throughout the kidney, as you can see in the picture, right? As these enlarge, they compress the healthy nephrons. They reduce blood flow, progressively destroying renal tissue. Patients commonly develop hypertension, hematuria, flank pain, because remember, the kidneys are in the back, right? You feel it in your flank, and enlarged kidneys. Wilms tumor or nephroblastoma is the most common kidney cancer in children. It usually presents between the age of 3 and 4 and often appears as a painless abdominal mass. Early diagnosis significantly improves survival rate. And as you can see here, there's this huge mass on their kidney. So before we discuss chronic kidney disease and end-stage renal disease in more detail, it's really important to understand how kidney damage progresses over time, right? The little diseases here and there, little problems here and there, if they're not fixed, then it progresses to something really bad. The process often begins with kidney injury or disease such as diabetes, hypertension, glomerulonephritis, infection, obstruction, exposure to toxins. So it kind of starts off over there. Initially, only some nephrons are damaged, so the kidney can still function with the remaining nephrons, right? So if the cause is identified and treated early, then kidney function can partially or completely recover. However, when the kidney damage persists and it's not treated, nephrons are permanently lost. The remaining healthy nephrons attempt to compensate by increasing their workload and filtration rate. And this process is basically called hyperfiltration. While the compensation helps maintain the kidney function temporarily, the increased pressure gradually damages the surviving nephrons, right? Because now you're putting too much workload on those nephrons. They're trying their best to compensate, but they just can't keep up with it. Over time, the progressive scarring develops within the kidney, particularly in the glomeruli, leading to a gradual decline in the GFR rate. As more nephrons are lost, the kidney becomes less able to regulate fluids, electrolytes, acid-base balance, blood pressure, and hormone production. This stage is known as chronic kidney disease. Now, as CKD, chronic kidney disease, progresses, nephron loss continues until the kidneys can no longer maintain homeostasis. Now, when approximately 90% or more of the nephrons have been destroyed and the GFR falls below 15 milliliters per minute, that's the filtration rate, the patient basically has reached end-stage renal disease. Now the kidney is done, right? It's fried. So at this point, severe complications develop, including uremia, fluid overload, hyperkalemia, metabolic acidosis, anemia, bone disease. Now, because the kidney can no longer adequately filter the blood, patients will require dialysis, kidney transplantation, and kidney transplantation if they want to survive. A simple way to remember this progression is kidney injury leads to nephron damage. Nephron damage leads to hyperfiltration and scarring. This scarring from the hyperfiltration leads to chronic kidney disease and then continued nephron loss chronically, eventually results in end-stage renal disease. So acute kidney injury is basically a sudden decline in kidney function. Sometimes it occurs over hours to days. Now, this doesn't mean that it's somebody who has kidney disease who gets this. It could be any damage to the kidney. It could be damage from a medication. It can be damage from a motor vehicle accident or somebody who had sepsis or MODS, anything like that, right, can cause the kidney to get injured, right? It's a sudden injury occurs over hours to days. Now, as the filtration is decreased, nitrogenous waste accumulate rapidly in the urine, and then the output declines. So now you're not going to have enough output. That's why it's so important to monitor urine output all the time. AKI is classified as pre-renal, intrarenal, or post-renal based on the location of the problem, the location of damage on the kidney. So pre-renal, this cheat sheet, I created that has all three of these explained. Please print it out, review it. If you want to, I know the wording is a little small. I tried to, try to get all the information in there. But pre-renal AKI results from decreased renal perfusion. So you're not getting enough volume. So that's before the problem is before it even gets to the kidney. Pre-renal, right? So it could be because of dehydration. Maybe the patient was in a car motor vehicle accident and they're bleeding out, right? So hemorrhaging. It can be caused by shock or sepsis or heart failure. So now you don't have enough volume, so the kidneys are not getting perfused. Intrarenal AKI, kidney injury, results from direct tissue injury, such as acute tubular necrosis, nephrotoxins like medications that, cause actual damage to the kidney itself. So it's intrarenal, inside the kidney. So glomerulonephritis, you have obstructions or inflammation or damage to the tissue, or contrast-induced injury. For example, people who going for a procedure and they're given contrast dye, that can damage the nephrons. That's why it's so important when patients have, procedures with contrast dye. We encourage them to drink a lot of fluids to dilute that contrast dye so the kidneys can excrete it without damaging the kidney. Post-renal AKI occurs when the urinary outflow is obstructed. So they have enough volume coming in. The kidney, the tissues and stuff, the nephrons aren't damaged, but the urinary outflow is obstructed by stones, tumors, and large prostate. So even though it's making the urine, it's obstructed. It cannot get out. So that's called post-renal, after passing the kidney, after the renal section. Because remember, the acute kidney injury is basically pre-renal, intrarenal, post-renal, depending on the location of the damage. So patients commonly will develop oliguria, low urine output, right? Because there's an obstruction, it's not coming out. Elevated DUN and creatinine, hyperkalemia, now it's retaining the potassium and not excreting it, so it's staying in there, right? Fluid overload, pulmonary edema, and uremia. AKI progresses through initiation, oliguric state, diuretic, and recovery phases. There are 4 phases, and these are listed down here. Now let's talk about chronic kidney disease. So unlike AKI, acute kidney injury, chronic disease develops gradually over months to years. Because remember, we said it's hours to days with AKI, right? It's months to years with chronic kidney disease. Now, the progressive nephron loss, if it's not treated, then the progressive nephron loss forces remaining nephrons to work harder, right? What did we call it? Compensatory hyperfiltration. Although this initially maintains kidney function, it eventually damages the surviving nephrons and accelerates the disease progression. The most common causes, guess what they are? Diabetes mellitus and hypertension, the same culprits. Here is a cheat sheet for chronic kidney disease. Now, because the kidneys regulate multiple body systems, we know the kidneys have multiple functions, right? So chronic kidney disease causes widespread complications because it basically will affect everything that the kidney does. Fluid retention, because it's not excreting the urine, will cause edema, hypertension, and even heart failure. Potassium retention, because now it's not excreting the potassium, it's retaining it, can increase life-threatening dysrhythmias, because what does potassium affect? The heart. So if the kidneys aren't excreting it, it's staying inside the blood, in the blood, it can cause cardiac function problems like dysrhythmias. Reduce erythropoietin, because remember we said one of the functions of the kidney is to produce erythropoietin, which leads to blood, to making blood in the body. So now if we don't have, if the erythropoietin production is decreased, this can lead to anemia and fatigue. Impaired vitamin D activation, because now the kidneys also activate vitamin D. This can cause hypocalcemia, because now the calcium cannot be absorbed because it needs the vitamin D to be activated. And can also cause renal osteodystrophy. Accumulation of waste products, because remember we said kidneys help excrete waste. Now accumulation of these waste products results in uremia, which can affect nearly every organ system, because now you have these waste products in the blood. And where does the blood go? It circulates throughout your body, every part of your body. End-stage renal disease. Remember we said like that progression we talked about. Now, end-stage renal disease is basically the last stop for the kidney. Okay, so the end-stage renal disease represents the final stage. At this point, more than 90% of the nephrons have been destroyed. So imagine living with 10% of the nephrons, right? They're destroyed, and GFR falls below 15 milliliters per minute. If you look at this diagram here, this kind of shows you the GFR, glomerular filtration rate, right? This is over here, normal is 90 to 1 over 90, so 90 to 120. Early stage kidney disease is 60 to 90. Then you have 15 to 60 is kidney disease, and 0 to 15 is kidney failure. So the kidneys can no longer maintain fluid balance, electrolyte balance, acid-base regulation, or waste removal. Patients develop severe uremia, metabolic acidosis, hyperkalemia, anemia, and fluid overload. These are all things that can happen because now the kidney is not working. Here is a cheat sheet for end-stage renal disease. Please print it out or download it and please review it. Once ESRD develops, renal replacement therapy becomes necessary for survival. Now they're going to need renal replacement, right? And hemodialysis removes the waste and the excess fluid through an artificial filtration system. Peritoneal dialysis is also used. Uses the patient's peritoneal membrane as a natural dialysis membrane. Kidney transplantation will remain the only treatment capable of restoring near normal kidney function. Without dialysis or transplantation, ESRD is fatal, because without the kidney, we cannot survive. It is the main support mechanism for our heart, right? So it's extremely important. So basically the CRT that we find patients doing continuous renal replacement therapy in the ICU. They're connected to a machine. You have hemodialysis, peritoneal dialysis, transplantation. These are the only solutions once a person reaches end-stage renal disease. So today, basically, we looked at the major urinary system disorders and their pathophysiology. We discussed infections, inflammatory disorders, obstructions, vascular disorders like nephrosclerosis. We discussed congenital disorders like the Wilms tumor and polycystic kidney disease. We talked about acute kidney injury, chronic disease, kidney disease, and end-stage renal disease. We kind of talked about their progression. Now, as you continue, remember that the most urinary disorders ultimately affect filtration, right? When filtration is impaired, fluids, electrolytes, hormones, and waste products become imbalanced. This leads to widespread systemic complications. Understanding these pathophysiologic processes will help you recognize the clinical manifestation and provide safe, effective patient care. And that is it for our lecture on urinary system disorders.